Okay, so good afternoon, everyone. And once again, those who have joined recently, please rename your name on the Zoom so that we can count your attendance. So, good afternoon, and on behalf of OCI, I warmly welcome all of you to the first session of our Cataract Awareness Month education series. So, June is celebrated as a Cataract Awareness Month. The cataract remains one of the leading causes of visual impairment globally, and we as an optometrist we play a very critical role throughout the patient journey. Right from the early detection and referral to the post-operative assessment and visual rehabilitation, of course. So, as a primary eye care providers, we are often the first point of contact for the patients, experiencing visual difficulties, and we are uniquely positioned to facilitate the timely intervention and optimize the surgical outcomes. So today's session, which is a pre-cataract and post-surgery assessment, the role of optometrist, will focus on the essential clinical assessments, which will, help determine cataract-related visual impairment and the key elements of the post-operative care. So it is my pleasure to introduce our speaker for today's session, Ms. M. Sushmita. She is a consultant optometrist and a faculty at Shankara College of Optometry, Hyderabad. She holds a master's degree in optometry from Manipal College of Health Professions and has extensive experience in clinical practice, teaching, and research. Her areas of expertise include Louis rehabilitation, specialty contact lenses, pediatric optometry, binocular vision assessment, and myopia management. And prior to her current role, she served as a senior optometrist and teaching faculty at Pushpagiri Vitreoretinal Institute. Ms. Sushmita has authored several peer-reviewed publications in international journals and has been recognized for her contributions to vision science and clinical optometry. She is passionate about advancing evidence-based practice and strengthening optometric education in India. So, welcome, Ms. Sushmita. We encourage all the participants to actively participate and make the most of this learning opportunity. So, without a further delay, I would like to welcome Ms. Sushmita for her talk.
Thank you, ma'am. Thank you for the introduction. Can I share my PPT?
Yes, yes, please. Go ahead. Yeah, it's visible.
It's visible, right, ma'am?
Yes, yes.
Yeah. Good evening, everyone. Welcome to the session series one. So I'll be talking about the pre-cataract and post-surgery assessment and what is the role of an optometrist. So optometrists play a critical role in co-management for cataract patients, conducting the initial diagnosis and pre-operative evaluations and counseling the patient and the post-surgery evaluations also. So today's my learning objectives are to understand the cataract assessment protocols and the identifying the what is the optometrist role in pre-operative evaluation and recognizing the post-operative assessment requirements and detect any complications after cataract surgery and what are the visual outcomes and what is the effective follow-up care post-surgery. So clouding of the normal clear lens of the eye due to a protein breakdown and clumping is called as a cataract. So, if we see the global impact, there's a 40% of blindness cases worldwide, making them the leading cause of reversible blindness. With the small surgery, they can get their vision back. So, what are the major symptoms the patients feel? So, it's a blurred vision, glare sensitivity, halos, reduced contrast sensitivity, and night vision difficulties, especially while driving. So we need to understand first what are the types of cataracts. So we have different types of cataracts. So each cataract affect one nuclear cataract. The cataract starts from the central where the near vision worsens, but their near distant vision versus but the near visual acuity will be very clear. So in the cortical cataract the patient faces glare halos and they feel difficulty in night driving. And in the posterior subcapsular cataract, there will be a fast progression in the development of the cataract, and they have very difficulty in the near vision. Congenital cataract is present at the birth. We can easily appear uh, while seeing the patient. Traumatic cataract, if there is any injury to the eye, you can see the cataract develops uh, immediately. Here you can see the images, how the first image shows where it is a normal clear lens, and the second image shows the nuclear cataract, and the third image is cortical and the posterior subcapsular. So by the slit lamp itself, we can identify what is the type of the cataract, and based on the patient complaints also, we can differential diagnose as what type of cataract. If the patient complains that his near vision is clear but the distant vision is getting worsens, then it's a type of nuclear cataract. If the patient complains that they have difficulty in the night driving, you can say it's a cortical cataract. And if the patient says that they have the distance vision is clear, they can able to read very nicely, but if you see the near vision is affected, it is a posterior subcapsular cataract. So in this point, we have to be very conscious in the taking the history what the patient is giving the complaint. Based on the complaint itself, we can differential diagnose what type of cataract the patient is having. So what is the role of the optometrist in this patient care? So early detection, comprehensive eye examination, patient education and counseling, referral for surgical management, and post-operative monitoring. So we'll see in each type what is our role as an optometrist. So, in the early detection, identifying cataracts during routine eye examinations. Patient might come for the general checkup without any complaints, like yearly checkup. But based on the complaints, you can identify either whether the patient is having cataract, or recognizing early symptoms such as blood vision, glare, halos, and around the lights, and reduced contrast sensitivity. So differentiate what type of cataract and what causes the visual impairment, and whether we can monitor the cataract progression, or whether we can go for the whether we can advise for the surgery. Is it required now or not? So early detection of cataract is very important. In the comprehensive eye examination, measure the visual acuity and refractive status, and perform the slit lamp examination by microscopy to assess the what type of cataract and severity it is, and evaluate intraocular pressure, assess the health of the retina, optic nerve, and anterior segment, conduct additional tests what is required to rule out whether.
Sorry to interrupt. I think your slide has been stuck. We
Okay,
can see only first point, early detection.
now it is changing, ma'am.
No, not yet.
Okay, I'll just. Is it visible, ma'am?
Yeah, it's loading. No, it's not visible for me. Can participants please comment in the chat box if they are able to see it? Yes, yes. It's not visible, Ms. Sushmita.
Okay. Now it's visible, ma'am.
Yeah, not yet, but it has started the screen sharing, but not the screen is not visible.
Okay. Now it's visible.
No.
Harshada, may I suggest maybe Shushmita can just leave the meeting and rejoin?
Yeah, I think that should be because our video is also stuck. So,
Yes.
Sushmita, yeah, you can just join the meeting again.
You can drop down. We will be there. You can rejoin with the same link and keep your video off when you're joining. Maybe the
Okay.
bandwidth is not that good. Yeah.
Okay, ma'am.
Yes, yes. Participants, please bear with us. Just give us 5 more minutes.
Yes, yeah. Yeah, it's visible now. Okay, meanwhile, those participants who have not renamed their Zoom name, please do that. I can still see Redmi and Realme. So please put your full names there so we can count you in attendance.
Yeah, can I continue, ma'am?
Yes, yeah. Yeah, just try sharing it now.
Yeah, is it visible?
No, not yet. Yes, Aarti, if you attend all three sessions, we'll give you the certificate.
Is it visible, ma'am?
No, it had come, but it is gone now. Otherwise, could you please email me the presentation? I can share it from my laptop.
Yes, ma'am. Sure.
There is a problem. Yeah.
Is it visible now?
Not yet, Sushmita. Not yet.
1 second, ma'am. I'll send an email to you.
Yeah, yeah, yeah. Yeah, it's there now. Yes.
It's there, ma'am. Okay, fine.
Yeah, yeah.
Yeah,
I've seen.
yeah. It's slides are changing, right, ma'am?
Yeah, yeah, they are moving. Yes. Yeah.
Okay. So in the comprehensive eye examination, we have to measure the visual acuity and refractive status, and we have to perform the slit lamp biomicroscopy to assess anterior chamber depth, how is the cornea integrity, status of the cornea, and to assess the type of the cataract and what is the severity of the cataract, and we have to measure the intraocular pressure, and we have also has to assess the health of the retina, optic nerve, and the anterior segment. So we also need to conduct additional tests such as contrast sensitivity test and the glare test. If required, color vision is also important to assess. So in these images, we can see the different type of the cataract and the stage of the cataract. We can able to assess and the grade. So in detail, we will be seeing in the coming slides. And the third one is the patient education and counseling. So we need to explain the nature and the progression of the cataract to the patient in the patient's understandable language and the layman terms. And we need to discuss about the treatment options and what are the expected visual outcomes, and educate patients about different intraocular lens options. So previously there were only limited number of intraocular lens options. Now we have variable intraocular lenses which corrects toric, multifocal toric, and EDOF lenses. So based on the patient, our lifestyle consideration and the occupation, we need to advise lenses accordingly. So we address the patient's concerns and what he is expecting the post surgery, and regarding his the lifestyle needs, and provide proper guidance and post operative care, and referral for the surgical management. So when determining when cataract significantly affects the daily activities and the quality of the life, then refer the patient for the cataract surgery, and provide detailed and clinical examination results, including ocular biomicroscopy details and the intraocular lens, coordinate between the patient and the surgical team. So what is the post-operative monitoring? So assess visual recovery following the surgery, post 1 week, post 1 day, 1 week, and 1 month. Monitor how is the wound healing and the incisional scar, and whether the corneal clarity is same as the pre and post cataract, and check intraocular pressure and detect any signs of inflammation like cells, flares, and identify any complications, whether they are leading to any edema, or cystoid macular edema, and any PCO, and perform post-operative refraction and prescribe spectacles when required. So when we have to do the post-operative refraction, all I will be discussing. So what is the pre-cataract assessment? What we do? So in the history, when the patient in the visual complaints, so as what is the patient's primary visual concern. So what is affecting the how the vision is affecting the daily activities, whether the vision is blurry or cloudy vision, or whether they have difficulty in reading the fine print like newspapers or medical prescriptions, or how is the difficulty in the night time or in the morning time, and whether they have the difficulty in the driving especially at the night, and increased sensitivity to bright lights or reduced contrast sensitivity, or colors appearing faded or yellowish. So you should ask all this detailed history, how it is affecting the daily activities. So it can be like simple question like how is your vision affecting your daily activities. So, coming to the medical history, so review the complete systemic conditions that may influence cataract development or the surgical outcomes. So, the important systematic conditions can be diabetes mellitus. So, when they got diagnosed, since when they are using medication, are they under the oral medication, or whether they are using insulin, if insulin since when, and how is the HbA1c levels or fasting blood sugar levels. You need to document all this. And hypertension, cardiovascular disease, autoimmune disorders, any history of radiation exposure, like based on the occupation, are they getting exposure to the radiation exposure, is whether they're having the habit of smoking or an alcohol usage, and in the previous surgeries whether they had any cardiac procedures, because they might be using blood thinners for of post cardiac surgeries. So you as a patient has supposed to stop the blood thinners before the surgery. So this has to be important when documenting in the medical history. Any neurological conditions they are affected with, are they under the treatment, and any systemic surgery affecting the overall health. So these detailed medical history is very important to document. In the coming to the ocular history, obtain the previous eye conditions and treatment, ask about the previous eye surgery, any eye trauma or injury they had, any previous diagnosis of glaucoma or uveitis, any retinal disorders, whether they had high myope or whether they underwent refractive surgeries, any family history of ocular disease. This history has to be documented. In the medical review, we have to document whether they are using any steroids for any other health conditions, or glaucoma medications, or diabetic medications, and any surge. We have to see is there any chance for the surgical risk, and we have to plan the perioperative management accordingly. And we have to see if any medications are causing for the development of cataract. For example, if they are using steroids for any other health conditions, they can develop the steroid induced cataract. So we have to identify possible causes of cataract development in those patients. So in the clinical examination, what we have to see in the visual functioning assessment. So we have to see the visual acuity. So we had to measure how clearly the patient has seeing. So we have to test using Snellen or logMAR chart, and contrast sensitivity, measure how the air ability to distinguish objects from the black background. So cataracts can reduce contrast, especially in dim light, and helps explain visual difficulties even when visual acuity is good. So we have to do glare testing. So glare testing evaluates vision in bright light conditions. Patients with cataracts often experience glare, halos, and difficulty in night driving. And we can use BAT and PAM tests to assess the glare test. And we have to see the refraction in objective and subjective refraction. So we have to determine refractive error using retinoscopy or AR. and we have to see the fine prescription based on the patient response. We have to see how much the visual acuity is being improved with the correction both in for distance and near. And we have to see any myopic shift assessment. So we have to check for increasing nearsightedness causing by nuclear cataracts. So patient may notice improved near vision and but frequent change of glasses. So this helps to determine whether the patient needs to go for the surgery or not. So coming to the slit lamp, we have to check eyelids and adnexa, any blepharitis, infection, or lid abnormalities. So identifying these conditions may increase the risk of post-operative infection. So we have to find out before and give treatment accordingly. Conjunctiva and sclera assess for any redness, inflammation, or ocular surface disease. Corneas evaluate corneal clarity and transparency, look for any scars, dystrophies, edema, and regeneration. Possibly try to assess tear film and see any signs of dry eye before surgery. So check for the anterior chamber depth and any signs of glaucoma, and look for any signs for previous ocular diseases. Iris and pupil check for the size, shape, and reactivity. Assess pupillary dilatation and reaction, which is very important for the surgery. And for the crystalline lens, so find the type of cataract and the severity. Grading the severity of the lens is very important, and evaluate how it is affecting the visual function. And lens stability, see the if phacogenesis or zonal weakness is present. So this helps for us to give a sign for the surgeon to keep any backup lens or take the keep the high risk support while performing the surgery. So this information is very important for when we are planning for the surgery. So tonometry measure intraocular pressure, which helps to detect glaucoma and other eye conditions. Fundus examination evaluate retina, macula, and optic nerve and blood vessels, and identify any retinal disease that may affect your visual outcome after cataract surgery. So it is better to perform OCT before surgery and include as assessment package. And it's useful for detecting any macular edema or degenerations or any other pathologies or family inherited diseases. So it's better to assess the dry eye assessment, evaluate tear film quality and ocular surface, which is very important for accurate measurements and for the surgical outcomes. And see for the corneal topography, if the cylindrical power or astigmatism is present, and how is the curvature. And it's helpful for to go whether for the toric lenses or the monofocal lenses. So it helps for the better outcome in the post surgery. B scan, when you are not able to see the fundus, B scan is advised if needed. So, what are the additional tests we see is required for the cataract? As I was telling, the glare and halos are the major complaints by the patients who has diagnosed with cataract. So, you can see the brightness acuity test, which evaluates the effect of glare on visual performance. It helps for the visual functional vision in patients with cataracts. So useful when patient complaints are more greater than expected from the visual acuity findings. And potential acuity meter, it estimates the potential visual acuity after cataract surgery. So it helps in predictive post-operative visual outcome, useful in patients with dense cataracts or suspected retinal disease. So we can show to the patient how their visual acuity is seen before surgery itself, like after surgery, how they can see the visual acuity. So Medox rod test, if there is any indirect information about central fixation, or if there is any large scotomas to find out, we can do the Medox rod test. Color vision test evaluates the color perceptions in cataracts, especially nuclear cataracts can reduce color discrimination. So color vision test helps us to document the baseline visual function before surgery. Ansler grid, like if any scotomas or metamorphias, if previous retinal disease diagnosed with retinal diseases, it's better to do Amsler grid before the surgery and explain what will be the visual outcome post cataract surgery to the patient. So patient might have the lesser expectations. So coming to the biometry and calculations, so we need to measure axial length, that is distance from the front surface, anterior surface of the cornea to the retina. It helps in essential for accurate IOL power calculation. Keratometry helps to measure the curvature of the cornea and helps in determining the corneal power and detect the astigmatism. And if required, we can go for the toric lenses and the anterior chamber depth, the distance between the cornea and the natural lens. So it is also important for precise IOL selection and the surgical planning. So the values we are saying are the acceptable thresholds when between the inter-subject and intra-subject. The K readings from if there are two K readings, it should be less than 0.10 diopters between intra and inter-subject inter-examiner variables. So axial length should be less than 0.10 mm in the both eyes, and with the inter and intra-examiner variables. ACD, anterior chamber depth, should be less than or equal to 0.05 mm, and axis should be less than or equal to 5 degrees, and cylindrical difference between should be less than 2 degrees. If it is more than 2 degrees, it is better to advise a topography. So now you had the biometric calculations. Now we have to see what we can calculate the IOL power. So the major formula we use is SRK formula. If you see P, that is equal to IOL power, P equal to A minus 2.5 into L minus 0.9 into K. So P stands for IOL power. What is the IOL power we need to suggest for the surgeon to implant in the eye. A is the A constant of the IOL. A constant varies for different IOL companies and materials. So we need to check with the company on which lens we are going for and what is the A constant. Axial L stands for axial length. In the mm values we have to take, and K stands for average keratometer readings. So we have other formulas also. So other formulas, SRK by T, Hoffer Q, Holiday 1, Haggis, Barrett Universal 2, and Kane formula. So these formulas need, additionally we need lens thickness and wide to wide for the precise actual and precise IOL calculation power. So here is an example of your biometry sheet. See, if you see towards the right side, it is having K values, T flat, and astigmatism. If you see at the pointer, there is a total astigmatism. So we have to look for the total astigmatism, what it is, say steep K value and flat K value, and what is the anterior astigmatism. So this patient has anterior astigmatism of 0.23 diopters in the right eye and the left eye 0.6. So coming to the total, which includes anterior and posterior, it is 0.20 diopters for the right eye and 0.60 diopters for the left eye. So coming to the axial length, it is 23.36 and 23.36. Its axial length is same in the both eyes. So if you see here, there is an SRK by T formula was used this, and the A constant is 119.30. If you see in the second box, if you can see, it is 118.70. So for the different lens has a different A constants. So based on that, the calculation will be given. So here we can keep the target refraction is 0. For the pediatric cases, we can keep the we can change the target refraction, and we can calculate accordingly. So this patient doesn't have much cylindrical power, so we can go for the monofocal lenses or multifocal lenses or extended depth of focus lenses without any toric power. So if you see for the second case, so there is an astigmatism of one diopter, and for the right eye and the left eye it is 1.4, and the axial length is difference is 0.15, which is acceptable. So if you see the total astigmatism, it is 1.41 diopters for the one eye, and the left eye it is 1.79. So if any patient having the astigmatic diopter difference of one diopter, we can advise for toric. So for this patient, if we advise only the monofocal lenses, they might need to depend on the spectacles post surgery for the astigmatism power. So for these patients, we can advise toric IOL lens. So if we see the toric calculation, here we can see where we have 1.50 diopters is a cylindrical IOL, and the correcting plane is 1. So the cylindrical power, we can use the toric IOL for this patient. So there will be a minimum dependency on the spectacles in the post surgery. So we need to find out what type of IOLs we are going to advise. So we have to be very careful in doing these calculations. So here it's an specular microscopy. I was telling we have to check for the corneal integrity. So it gives complete the endothelial count. So we can find out if there is the corneal integrity is not clear. We can just give an indication for the patient that post surgery they might have the less visual outcomes. So in the IOL options, now we have done the biometric calculation. So now we know we have an option to explain to the patient what type of IOL is suitable for the patient. So we have monofocal IOL, multifocal, toric IOL. So monofocal IOL provides a clear vision at one distance, usually only at the distance, and so the patients may still need spectacles for the near task. So multifocal IOL, which provides distance for 3 zones: intermediate, near, and distance. So, and in multifocal, there is a less dependency on the spectacles. Toric IOL, which corrects the corneal astigmatism and improves visual quality and reduces the need of glasses. So if you see the image, there are monofocal lens IOL, multifocal IOL, trifocal, and extended depth of focus. Head of lenses will give correction up to near 60 centimeters. So for near at 40 centimeters, they will be able to read N8. So for the N6 visual acuity, they might need to use the spectacles. So there will be less dependency for the spectacles for near, and the toric IOL for the astigmatism correction. So now we will explain what type of IOL will be suitable for the patient, and we can advise so which will be suitable and the less dependency for the spectacles post surgery. So now we need to counsel the patients about the surgery procedure of overview, like explain about the cataract surgery process in the simple terms, and how inform the patient about the cloudy lens it will be removed, and this IOL and artificial IOL will be placed, and like it's assure them that it's a safe and commonly performed procedure, and it's a day care procedure, and no need to admit in the hospital. Like most of the hospitals, there will be no need for the admission, like it's a daycare hospital. And the risk and benefits, what are the precautions they need to take, and benefits will be like improved vision, they can have the better quality of life, and they will have the reduced glare and visual disturbance. So risk can be infection if the proper drops or hygiene is not maintained post surgery, and if there are any chances of intraocular pressure increase. So there will be a rare complications risk affecting the vision, and the expected outcomes will be most patients experience there will be a significant improve in the vision. And what are the lifestyle considerations? So the few patients will be asking how the surgery will be performed, what is the type of the technique. So we need to know what are the common techniques where we perform surgery. So one is phacoemulsification, which is the most commonly performed cataract surgery, uses the ultrasound energy to break the cloudy lens into small pieces, and these lens fragments are removed and replaced with an intraocular lens. So there will be a small incision in the temporal side, and it's a fast healing and the quick visual recovery. And it's a small incision cataract surgery, SICS or MICS. Cataract is removed through a self-sealing small incision. Here we do not use any ultrasound, but it is little bit cost effective, and only when the dense cataracts are there, this SICS is advisable. And femtosecond laser assisted cataract surgery, which gives provide high precision and accuracy, so which may improve the surgical consistency. Generally, it is more expensive than the conventional. So we need to know how the surgeries are performed, what are the techniques of this surgery, and we need to explain to the patient in their understandable language. So now the surgery is done. So what is the post-operative assessment schedule you manage? So at the day one we have to measure the visual acuity, intraocular pressure, and see at the wound integrity and the corneal clarity, how is the cornea. If possible, if there is a chance, you can do the specular in the post day one. So day one also, and you can compare how is the pre and post, if there is any change in the corneal clarity. And we have to see at the incision mark whether it is healing or any leakage from the incisional mark. And at week one we have to see how is the healing process, and if there is any inflammation inside the eye in the AC, any say cells or flares are present, and how is the patient comfort, he's comfortable seeing the way seeing. And medication things, how, are they using the medications properly. So, and in the first 1 month we have to see the final refraction and give best corrected visual acuity, and if required spectacle prescription you can prescribe. And the third month it's any long-term visual outcome, and in assess the ocular health evaluation and detect any late complications like PCO. So medications we have to see, like antibiotics will be given 4 times a day for 1 to 2 weeks, and steroids you have to start from 4 to 6 times per day, and you have to taper it to the 4, 3, 2, 1, or if it is 6, 6, 5, 4, 3, 2, 1, and we have to taper it. We have to make sure the patients are tapering or not. Sometimes the patients might get confused and they taper the antibiotics and continue the steroids. So you have to check with the eye drops. Ask the patient to bring the eye drops on the day 1 week and 1 month, and check whether how they are using the eye drops. And NSAIDs will be for 1 to 3 times per day for 4 weeks, and you can add lubricants if required based on the corneal condition, and you do dry eye test before the surgery, right? So based on that, lubricants can be added if required for 4 to 8 weeks. So, what is immediate post-operative assess? So, we check for the visual acuity, assess improvement in vision in post-surgery, and compare with pre-operative visual acuity. You can just show the difference for the patient, and check for the corneal clarity. Examine for the cornea for any edema or any corneal haze. And clear, if it is clear cornea, it means there is a good healing. And check for the wound integrity, check for any surgical incision for leakage or infection, and ensure it is healing in the follow-ups. So anti-chamber reaction, assess for any inflammation cells or flares, monitor the eye surgery response, and IOP measurement measures intraocular pressure and detect any spike in IOP or any risk for glaucoma. So the 1 week, 1 month, this check, all this should be included in your assessment. So, what can be the common post-operative complications? There can be early in the 1 week or 1 day. You can see corneal edema, which is the swelling of the cornea after surgery, which the indication will be blur vision, and it usually improves with the time. If there is any elevated IOP, temporary rise in eye pressure, which requires monitoring and treatment to reduce the IOP. And if any chance of endophthalmitis, like severe infection in the eye, the symptoms can be pain, redness, and decreased vision the post surgery also, which needs the urgent requirement treatment is necessary for this condition, for this sign. And uveitis, any inflammation inside the eye, redness, pain, and light sensitivity. So it will be managed with anti-inflammatory eye drops, but still if it is severe, it's better to report the concerned surgeon. So the late complications can be posterior capsule opacification and clouding of the lens capsule behind the IOL and any cystoid macular edema. So this there can be swelling of the macula and leads to reduced central vision. So diagnosed with OCT and treatment with anti-inflammatory medications. So performing OCT before the surgery can be like indication, and you can counsel the patient accordingly so they can have the less expectations on the visual outcomes. So usually perform refraction at 4 to 6 weeks after surgery. Once the eye has healed and the vision has stabilized, so determine the patient best corrected visual acuity and identify any residual refractive error. Whether it can be point plus or minus myopia 0.5 diopters, or any chances of induced astigmatism or any corneal astigmatism if the patient is not going for toric IOL. So used to prescribe the final spectacle correction if required, and evaluate the effectiveness of the selected IOL. If there is a toric IOL, you can show them like there will be less dependency on the spectacles. So, and you can give the glasses accordingly. So patient education, you have to give instructions about the use of medications correctly, use prescribed eye drops as directed, and follow the dosage and schedule carefully, and do not stop medications without consulting or without advising by the doctor. So avoid eye rubbing, do not rub or press the operated eye, protect the eye from the accidental injury, like better to use the shield up to 1 week or the black spectacles. And maintain hygiene, wash hands before using eye drops, and keeping the eye area clean and avoid contaminated water, and avoid direct contact with water and dusty environments during recovery, and cleaning up the eye after installing the drops. Otherwise, all the particles can accumulate at the eye lashes, and that can also lead for your infections. And attend follow-up visits at the scheduled post-operative appointments, and regular checkups helps monitor healing and detect the complications. So here is an protocol we use at our hospitals. So the first page is like after counseling in the room, this sheet was given to the patient, and it's clearly be direct to the patient. It's like which room they have to go for the scanning. So first they have to visit room number 16, then ocular imaging room. In there we do, in first room number 10 we do IOL calculation, A scan, specular, we test for the PAM and the color vision, and we include OCT as a mandatory test in our protocol, and then lab investigations and PS like pre-anesthetic checkup. So the below sheet is like pre-operative instructions we give in the written format to the patient. So patient was supposed to get all the pre-operative eye drops as indicated, and they are supposed to use like all carry the systematic medications, any using for any hypertension, BP, asthma, they are supposed to carry. And what directly they are supposed to report at the nursing station, and one patient and one attender. And so, and waiting time post surgery, if there is an incidence, it takes some time for the incidents, and to have the breakfast and come. So it's a clear written indication, helps the patient. So how much time it takes, if it can be delayed also sometimes because the number of surgeries. So clear instruction written format helps the patient to have a clear overview. So the second sheet is about the instructions to be followed by the operated patients, like face wash, how when to do face wash, and how I bright light, and uh, do not sleep towards the operated eye for 15 days, and no shampoo wash. So it's a clear indication, and it's better to give in the local language which the patient can able to understand. So it helps for the proper management and post-operative instructions. So I have a few cases to discuss. So here is a case one, which is 62 years old female. So she came for the checkup, general checkup, and she knows her vision is getting blurred, and she came for the cataract. So both eyes she was using glasses since 2 years, and she had only Calazian surgery. So if you see her uncorrected visual acuity is 6 by 36 and 6 by 18, and near it is N14. So the patient is an hyperopic, and they have in the keratometry readings we can see it's only 0.5 cylindrical in the right eye and 0.25. Though the visual acuity is 6.6 in the right eye, and it is improved to 6.12 with the glasses. It's 6.12. So the best corrected, if you see the hyper patient was using plus 3.5, but it was reduced, there was a myopic shift. So myopic shift because there is a chances of nuclear sclerosis. So if you see in the examination, patient have NS1 and cortical 1 stage in right eye, and NS2 and C2 in the left eye. So there is a cup disc ratio of 0.5. If you see, there is no previous history of glaucoma or medication, but patient had peripheral iodectomy. So in our examination, we got there is a suspect of glaucoma in this patient. So in the ocular biometry, so patient had gone for the eye hands lens since the toric is not there, and we perform OCT. OCT is also fine, and we have done RNFL. It's also fine. There is no damage in the retina with due to any glaucoma changes. Also, there are no glaucoma changes. And if you see the specular count, the corneal integrity is good in the both eyes. So patient had the surgery for the left eye. So in the post-operative, the post-op, it's a one day post-op. The patient is reading six parts, and near it is N8. So it is an eye hands lenses. It means the extended depth of focus. So intermediate they will be able to see clearly. So for near they can use a minimal power. For till near they can read N8. So if you see in the post-op one day the patient is reading six parts, that the remaining complete clarity will be also healed in the 1 month, and the patient visual outcome was very good. So if you see, there is another case of 63 years old male. So his occupation is a driver, and he is complaining of glare in both eyes while driving, especially in the evening hours since 15 days back. So he's also having diabetes, and he's under medication and hypertension. So if you see the patient vision, a vision with the best corrected was 6/9 blur and N6 and 6/9 parts. So both eyes he's having nuclear sclerosis too. So this patient had right eye surgery, and he's also having minimal uh, cylindrical power, so toric lenses was not advised, and he also underwent with EDOF lenses. So his retina is also fine, his OCT is fine, and the corneal integrity is also fine. So in the post-op 1 week, his best corrected was plano with 6/6 in the right eye, and with without any correction, his reading N8 for near, and with correction, it's N6. So, coming to the end of this session, the summary, the optometrist plays a very important role in before and after cataract surgery, and complete comprehensive preoperative assessment helps us to ensure the accurate diagnosis or selection of IOL power and proper explanation or appropriate management. And the post-operative monitoring helps in the early detection, and any complications are there, we have to find out easily. And accurate measurements and evaluations helps in the better visual outcomes. So when we are doing biometric calculations, the accurate measurements gives better visual outcomes and the better patient satisfaction. So main important thing is patient education and counseling, which is very important being an optometrist, and help them to understand what actual the condition is and how can be treated, and what can the patient expectations and the overall quality of care. Yeah, thank you, ma'am. So you have anyone have any doubts?
Yes, thank you. Thank you, Sushmita. It was a very thorough, detailed presentation. You had all pre-operative assessments, IOL calculations, IOL types, then post-operative complications, everything you covered. Okay, before going to the questions, I would like to know from the participants how many are, practicing privately, or they have any optic not associated with the hospital. How many are of there present in the audience right now? Or they must be having private practice or any optical shop or any other jobs, but not associated with the hospital. And those who are, seeing cataract patients maybe once or twice in a week or something like that. Okay, one is, yeah, okay, Mr. Zahur. Anyone else? I'm sure there must be private practitioners who have joined these sessions to know, how to deal with the cataract patients in their practice. Any other participants? Okay, Ranjita. Anyone else? Okay, Manisha. Okay. So, are you guys see cataract patients maybe in a week, in a monthly basis? How do you see them? Yes, Bhargavi. Yeah. So, can any one of you unmute and just let us know what are the challenges when when a cataract patient comes to your practice, how do you deal with it? Or, any challenges explaining them, or counseling them, or maybe in referrals? Anyone? Okay, maybe they don't want to share it. Ms. Sushmita, I would like to ask you that, you shared a protocol for the hospital, those who are in the hospital. But if it is
Yes.
a private practitioner and, sometimes patients travel for the cataract surgery, they want to get it done from the specific opthal, or, their relatives are staying there, whatever may be the reason. But they travel in the city, and when they come back to their own city, they go to the private practitioner or the optoms who are nearby then.
Yes,
So
yes.
how do these optoms, should tackle these post-op patients, or how should they? What should be the protocol to for the assessments and, of course, for the referral?
Yes, so post surgery, so to understand what type of lens is implanted, they might patients might carry the post surgery details or discharge summary. So discharge summary itself tells you like what lenses are implanted. So if based on the lens implant, you can do the refraction, and like in the question chat box, they are telling EDOF lenses. So it is difficult to find out EDOF lenses through slit lamp. I agree, but you can find out the multifocal lenses through slit lamp, and you can prescribe or you can do the refraction accordingly. And if most of the hospitals do not do OCT or do not see the fundus properly before cataract surgery, so but you can do it. You can find out what are the changes they are having, and you can refer accordingly for the other surgeons or for the required treatment.
Okay, okay. Yes, we have a few questions in the chat box. Mm, okay, the first one is I want to know the formation of the PSC in myopic individual. So, Ms. Sushmita, have you any idea about this, or we can cover this question maybe tomorrow when Dr. Balasubramaniam will be joining us. So, I think he would be the best person to answer this question.
Yes.
Next, we have biometry should be done in dry state or post dilation. Does dry state biometry data plays a crucial role due to the pupil size factor, or any other factor plays a role?
No, like we had done a study, like whether the dilatation is affecting in the axial length or gatometry values. So there is no changes in the pre and post dilatation. So anytime is fine.
Okay, okay.
What are the changes we can say are the very negligible changes, so which will not impact on the surgery or the IOL lens calculation.
Right,
So
right.
sometimes in the PSC and the dense cataract, post dilatation gives you the proper axial length.
Okay. Okay, next is can we do wet refraction and fundus examination in our own clinic practice? Yeah.
So as an optometrist, if dilatation is not allowed by an optometrist, but if you have any support from the other ophthalmologist, you can do it.
Yes. Yeah. Fundus examination, yes, of course, you can do it if you have a proper equipment and everything. So, and if you have a good experience, you can do that. Yeah, okay. In EDOF 5OLs, if unaided near vision is N10 or N8, can we give just plus 0.75 or plus 1 add for
Yeah.
near?
For EDOF lenses, you can start from plus 1.5 diopters. 1.75 and 1 will not be sufficient for the patient. You can start with 1.5, check for the near vision, and then you can increase and see. You can give 1.5, and again depends on the patient needs. You can increase or you can give 1.5.
Okay. And yes, I mean, in EDOF, is there any consideration in prescribing ad? Are there any
Yes.
criteria or, yeah?
Start from 1.5 and go according to the patient comfort. And if the both eyes are operated, better to check your near vision binocularly.
Okay. Okay. Do we need to do any further scan or investigations for EDOF lenses, or is it
No,
similar as other?
no scan or further investigation is required for EDOF lenses. It depends on the company. Company will be calculating the EDOF lens, and it's same like the monofocal lenses only. But the lens designed are based on the extended depth of focus. Additional requirements are not required from our side.
Okay. And does GAT affect the biometry scan?
If you do not indent the cornea, it's fine. If you indent, it will affect the biometric scan. So experience with better no indentation, it's fine.
Okay, regurgitation test is important for surgery or
Yes,
not?
yes, yes,
Yeah.
yes. It is important. You had to check. You had to check it before the surgery itself.
Okay. Okay, Ria is asking for multifocal IOLs. Does biometry values change post dilatation as compared to undilated biometry data? Multifocal IOLs, does biometry values?
No, like after implanting multifocal, we do not do again any biometric
Ah,
changes, right? So
so,
we do it only pre. So post, if it changes also will not be a problem. Like we can do biometry anytime post dilatation or pre dilatation, but that will not impact us in selecting the IOL powers, either EDOF lenses or multifocal lenses. That will not get any effect.
okay.
So proper thing, if we are calculating manually, we have to check for the A constant. If we have to keep the A constant appropriate value, then it will not be a problem.
Right, yes. Uh, okay, the cataract patients usually don't want to go for the surgery in summer season. So, any tips for the counseling such patients?
See, in every hospital, the scenario is the same. In summer season, the surgeries will not happen much. So, how much ever you try to convince the patient, they have a mindset that in summer it is heat, they will not do surgeries. No, it is the lens material is not going to get affected with this our normal temperature. So, they can go for surgeries in summer. There will be not a problem, but still again depends on the patient whether they wanted to go or not. But some hospitals, because of the holidays or vacation thing, surgeries will be normal in every season,
Yeah.
including summer also.
Yeah, so we have next why ophthals don't consider EDOFs in patient with diabetic fundus. So I think all these ophthal related questions will keep it for tomorrow's session, tomorrow and the day after ophthalmologists will be with us. Again, this question, how conventional phacoemulsification and FLSA. So that also question we can take up tomorrow. I will note all this down. Okay. Okay, how IOL calculation happens in congenital cataract and what is a suitable age?
So, according to the research for the congenital cataracts, again depending on the age, we have to keep the residual refractive error, because hematopization, the axial length changes, the eyeball size increases, again there will be a change in the refractive error. So as per the age, according to the age, we have to keep the refractive error, residual refractive error. I have showed you in the biometry thing, right? I kept 0 as my residual refractive error. So in that you can keep +2 or +3 based on the age, and you can go for the calculation. So according to that calculated power, you can advise IOL power can be selected.
Okay. Uh, okay, we'll take this last question. Post-surgery glass prescription should be given after how many weeks or days? And
See,
shall we give it after 2 days or 2 days of surgery? And should we give it after 1 week? I mean, what is the ideal period?
so
Uh,
ideally it's for 4 weeks, 1 month is ideal. Post surgery diffraction has to be done. Giving after 2 days of the surgery, I will not surgery personally, because the wound will be healing. There inside the complete infection, or if there any chances of infection, again it will be affected. So we have to give it after 1 month. If the patient is traveling somewhere, if the both eye surgeries are done, then I can advise for the 2 weeks, but not less than the 2 weeks. Otherwise your residual refractive error will affect, and there will be chances of changing the glasses. So the wound will be healing, right? So immediately after 2 days or 2 days or 3 days, you will get more power. So after 1 week, 15 days or 4 weeks, the wound will heal completely, and you will get the proper residual refractive error. So that will be easy, and the patient will be also comfortable, because visual acuity also will improve from day 1 to 1 month. So patient satisfaction is also important. At the patient vision is 6 pairs or 6 9 at the post 2 days surgery, and if you are giving the glasses, and after 4 weeks the vision is improved to 6.6, then what is the point of giving correction for the distance? There is no point. Only for the near we have to consider. So we have to check all the visual acuity, patient comfort before prescribing the glasses.
Correct, yes. Okay, and Jasna is asking, in case of post-op patient who is 28 years old, then what about the addition you give after surgery?
So based on the IOL, if they are going for EDOF, try with 1.5, and if they are going with monofocal, go with 2.2, 2.5. So here there will be no accommodation. It's not a natural lens, right? No accommodations will come in the place. It's a IOL lens. So you can go with the 2.5 or 1.5 according to the lens.
Yes. Thank you. Thank you so much, Ms. Sushmita, and thank you all the participants for engagedly, participating in the session. And of course, today's session, it highlighted the importance of comprehensive patient education, timely referrals, effective patient counseling, and of course, post-operative care. So, we as an optometrist, we play a very vital role in guiding patients through every stage of their cataract journey and, supporting their long-term visual rehabilitation. So tomorrow we have a second session, which is on premium IOLs and modern cataract practices. And in that, what optometrists should know. So Dr. Balasubramaniam will be with us. So keep your all ophthalmic-related questions intact. We'll take them up tomorrow. So thank you, Ms. Sushmita. Thank you for the wonderful,
Thank you, ma'am.
your valuable knowledge and all the practical insights on the role of optometrist in pre-cataract and post-surgery assessment. So thank you so much for being with us today. And thank you all the participants. Stay connected with OCI and continue learning. We have launched IC material, IC poster in the honor of Cataract Awareness Month. I would just like to share that with you all. Just give me a minute. I hope you can see the poster. So this is the IC poster. You can put your practice logo on this poster and put it in your waiting areas or hospital waiting areas just for the patient education, as a material you can use it. If you want your logo to be applied on the poster, please mail us on info@ocindia.org. And like this, we release IEC posters every month. You can find them on our website. We have right from the January to December, we have all 12 months, created posters as per the eye health calendars, which you can download them freely and you can use it in your waiting areas. So thank you all for being with us today. See you all tomorrow. Have a great day ahead. Thank you.
Thank you, ma'am.